so you can know how to measure next time. Okay. So that's another provocative test that we do. We also look at integumentary system. Okay, that's your skin. Okay, and the hand or the skin can tell you a lot about a hand. Okay, page 561, figure 22.8. This says that he has poor integument. What makes it poor? What makes it poor integument?
Wound on his thumb.
He's got a wound on his thumb. This looks like my poor grandpa's hand.
It's cracked. His skin's cracked.
Skin's cracked.
Small.
Yep. So that'll be something you'll want to also note in your documentation is their skin integrity. Let's see. Questionnaires are also things that, and I will make sure that you all have copies of questionnaires. I'll put it in the handouts section on eLearn. You can print those questionnaires out, put them in your binders and keep them for later on, future reference. So let's discuss Phelan's. There's a Phelan's test for carpal tunnel syndrome. There's also a Tennell's test. So I'll teach you those. And then we'll go over okay, let's go over those first. Haven't seen them yet. I think I can't. This isn't going to work, is it? Yeah, it's not going to work. All right. Well, if you have to watch the video, we're not going to be able to see anybody doing anything. All right, so the Phelan's test, you are going to sit across from your client. And have them put their elbows on the table. They've got a watch on, they may need to take it off. And they're going to hold in extreme flexion, okay, for up to 1 minute. You're going to count, and the second that they feel like their fingers are going numb, they're going to tell you. And you're going to see how many seconds that was. Okay. All right, so are your fingers going numb? Okay, normally if a person has carpal tunnel syndrome, within about the first 15 to 20 seconds, they'll start feeling a tingling, especially in the ulnar, in the pinky. Okay, but they'll start feeling tingling and like a numbing sensation in their fingers. Now, if they experience that, you don't say, well, you have carpal tunnel syndrome, because we don't provide diagnosis. Okay, no OT practitioner does. What we can tell them is that may be an indication of carpal tunnel syndrome. So you may want to go see your doctor and describe to him what it felt like. Okay, then the doctor will be the one to say if they have it or not. Okay, the next one is a Tennell's test. The practitioner will gently tap and this is just for like nerve irritation, but you check carpal tunnel syndrome this way also, just to kind of see if the medial nerve is gets irritated. So what you'll do is you will gently tap. Remember when they said the medial nerve? Where does it run? Okay. So you're going to just gently tap over that medial nerve. And if they got a watch or something on, depending on which hand they're doing.
Do you just have the rest area? Or do you go up?
I go up. I start like around here. And I go up like that and just gently tap it. Go up into their hand. And if they're experiencing nerve irritation, that's another common sign of carpal tunnel syndrome. Oh, Dequer veins. I had Dequer veins and that hurts. So the Finkelstein's test for Dequer veins tenosynovitis. Page 565. You have your client flex the thumb into the palm, okay? And then you combine that motion with ulnar deviation, okay? So you're flexing into the thumb and then you're deviating. If you have, now mine isn't acting up right now, but it does, yeah, if you've got Dequer veins, synovitis, it's just a nerve in your thumb, then it will reproduce the pain in the radial side of the wrist. Okay. Yeah, it hurts. Okay. Okay, and then there's an elbow flexion test. This is to rule out ulnar nerve compression. And we do this a lot now because people, what do you usually do all the time? People are always sitting like this for what reason?
Like this,
You got your cell phones, right? So a lot of times you will get compression, ulnar compression of your elbow. So what you're going to do is passively flex the client's elbow to maximum flexion and hold it there for 1 to 3 minutes. All right. If you test positive for an ulnar compression syndrome in the elbow, then it will cause numbness and tingling in the ring and pinky finger. Okay, so you just passively flex it all the way into flexion. Okay, and if you start feeling that, then you have ulnar nerve compression syndrome. All right, so what I'm going to do now is I'm going to show you all
I remember doing this Allen test for respiratory. Because of doing you had to prick someone right in the radial artery.
all right, so this is retrograde massage. Get this off here.
And this is for edema?
This is for edema. This is usually the most favorite part that My patients always loved. Now, who would you not do this with?
Just the part code.
Come on with the top ready because you're going to get. We're not in the, I'm going to use this. We're not going to, we don't want to. It's not fun. All right, so I need to take all that off, please. The reason that I wear gloves is because the other fluid comes out, okay? And I had some patients that had so much fluid, you can come around. I had so much fluid that I mean, it would literally pour out. So I always use a towel.
Where did it drip out at? So just the pores?
Yes. Yeah, I mean, sometimes there was a smell, but, you know, sometimes there wasn't, but there was usually like a yellowish liquid. So I always kept towels and stuff like that, okay? You don't have to. So what you're gonna do, now, you're gonna push the fluid up. Why are you gonna push it up and not down? Right, because if you push it down, it has nowhere to go. So, right, it'll stay right here. So you always start at the fingertips, okay? And you're gonna just start with the fingertip and just push that edema up past the knuckle, okay? On each individual finger. And this whole thing usually takes 20 to 30 minutes. Okay, but that's not going to be what we're doing. If you have to do this during a practical, you ain't gonna take 20 to 30 minutes. And then you also don't forget the thumb, push it out past the knuckle. Turn the arm over. Don't forget the palm of the hand, okay? Because just because you get the edema out of the back, out of the dorsal part of the hand, does not mean the palmar part of the hand is going to do the same thing. So also you do the same thing there. Concentrate on any little pockets of fluid that you find, because you will find several. If you see any little pockets, kind of concentrate on that, use your thumbs and push that fluid up and break up that pocket of fluid, okay? So you're gonna do the same thing at the rest of the arm. You're gonna, make sure any edema is pushed up. Any pockets of fluid, you're gonna work on that and then push it up past the elbow. Do the same thing on the other side, push it up past the elbow. And then what I always did was put their arm on top of my shoulder, and this is where it kind of got gross. When I had towels over there, you usually ended up getting soaked anyway, that's a shame. So you do the same thing with the elbow to push it up over the elbow. And you want to make sure that you get inside of the joint and feel around that joint, because of that pocket of edema, that fluid will tend to kind of concentrate in that joint, okay? You're going to do the same thing, go all the way up past the shoulder. You are going to have to go into the armpit, okay? So you are going to be playing in some pits, but that's okay. That's what we do. And I'm not going to do that, okay? But you want to make sure that you go past the shoulder and down. And all of this, that edema will probably pocket right here under the arm, okay? All of that's going to have to be worked out and pushed forward. Okay, because all these lymph nodes are going to be collecting those pockets of fluid. And, if they've got swollen lymph nodes, chances are, because what a swollen lymph node is, it just collects infection. Okay, so if you got a swollen lymph node, nothing to be real concerned about, it's just infection somewhere. But you want to make sure you get that fluid out, pushed back into their heart, okay? Then their heart will then pump it around, okay?
It sounds so crazy. It's like, you know how they say, like, eating, you don't want your arteries clogged up, you don't want that going to your heart. It just sounds so crazy. Yeah. Does that make sense? Like,
Well, it sounds crazy.
it's like how they say, like, clogging your arteries and stuff. Like, you don't want that going to your heart.
Oh, yeah.
It just sounds crazy.
Well, that's why we don't do it if someone has congestive heart failure, because they've already got too much fluid built up around there anyway. Okay. Let's see. All right, this got soft tissue conditions also. Look at page 567. These are some of your soft tissue conditions. The ganglion cysts, they are also known as Bible cysts. How many people's ever heard that term? A ganglion cyst, what they used to do, you know, have those big, great big heavy family Bibles? They would have one of these and they just take the Bible and they'd crack it up against that cyst and the cyst would burst. Yeah, we don't recommend that. But it has been done. Then you've got de Quervain's tendinopathy. If you look at figure 2213, this is where de Quervain's tenosynovitis occurs.
Oh, the thumb test.
Yeah, the thumb test. Usually just some kind of a custom orthosis, tendon gliding exercises for that, grip strengthening, pinch strengthening, things like that. Trigger finger is one that that's common, especially with rheumatoid arthritis. Okay, what happens is with the trigger finger is their finger will just get caught. Their tendon will lock up. Never try to pull it out. I had a patient who had trigger finger, you know, and I was trying to treat it. I was trying to get it out with like heat and just the normal things that I would do, tendon glides, things like that. She went, all right, it does it all the time. Oh, about that.
And it didn't hurt him at all?
Oh, it did hurt her. But she said, what else am I supposed to do? I have things to do. I don't have time to sit around and whine over a finger hurting. And I'm like, more woman than me. Of course, she did have like 15 kids. So, and I guess, you know, when they were younger, she really did have a lot to do. She didn't have time to sit around. Let's see. Now, flexor tendon injuries, one thing you need to note is flexor tendon injuries are harder to repair than extensor tendon injuries. Most often, they're not going to see us for flexor tendon injuries. Unless you're working directly with a certified hand therapist. Then, you know, the OTA will be the one to assist with like orthotic fabrications, dressing changes. We'll follow the provocative testing protocols, and, you know, do stuff like with protective range of motion, things like that. But most of the time, it's the CHT or the OTR who will be doing a lot of the treatments for the flexor tendon injuries. If you are doing, and I don't know if any of you all are, but if any of you all are working in outpatient therapy for your field work, and you need to maybe do some research and see if they see hands or people with hand injuries. If they do, then you'll need to come back to this chapter and pay close attention to the structure, the anatomy, and the physiology of the hand. You'll also need to look at the different zones, the flexor and tendon, flexor and extensor tendon zones. And you will definitely need to know on page 577, there's a series of tendon gliding and blocking exercises. So that'll be something that you'll want to focus on if that's the case, okay? Now, I will tell you that you will see some hand stuff on your MBCOT exam. It won't be really intensive stuff, like it won't be name all the metacarpals and the carpals and all that. It won't be like that.
I would know that. That's what I would know that.
Yeah, so, but when we go into OTA 216 and 217, those two courses, then you'll learn a little bit more about what they're going to ask as far as the hands and stuff like that. But you're really not going to do a whole lot with hands. We are going to do splinting, which is something I always found fun. I like teaching it. I like doing it. And usually a lot of my students say that that's one of their favorite chapters, just because they get out of the lecture and they just kind of invent something. And I wish all of them could be like that. I wish all of the lecture parts could be like that, but can't be. And I'm going to go to Charleston and teach them splinting also, which I look forward to. I enjoy it. Okay, is there any questions on